Okay guys, so at this stage we're going to go through some differentiation tests for our lumbar spine, hip and SIJ. And again, sometimes can be quite difficult to come up with a diagnosis because the symptoms can be quite varied. And so some of these tests are going to give you a little bit of a focus on what area you might need to look at more, or be able to clear certain areas as a source of symptoms. So first one, if we go through, Glenn, is our pelvic tilt. So what do you look for with the pelvic tilt?
Yeah, pelvic tilt's a nice one really, because if you think about the mechanics of what you're actually asking your client to do, if they're tilting forwards and backwards, what they're actually doing is flexing their hip and extending their lumbar spine, and then when they come back they're flexing their lumbar spine and extending their hip. So straight away, if you're getting pain provoked through one movement over another, you could almost start to hypothesize that it's an extension component of the lumbar spine, or a flexion component of the lumbar spine, or an extension or flexion component of the hip. So it's quite a nice, simple movement. Also gives you a good idea of how they're moving and what their kind of range is as well.
Yeah.
So if we ask PJ to do that then, I'm going to get you to face this side actually, I think that would be easier. And I just want you to rock your pelvis forwards, rock your pelvis backwards. And PJ's doing that really well. Sometimes people struggle a little bit with that.
So what would you, from a cueing point of view, what would you say to someone to cue that position?
A few different things. I like to use the analogy of the pelvis. I show them the pelvis, and then I like to use the analogy of the pelvis almost being like a bucket that they're tipping forwards and tipping backwards. I think that one works quite well. I'll put my hands around the area and I'll give them a little bit of tactile feedback as well to show them that they're doing that right. I'll show them on myself. So if you think how people learn things, they like to be told how to do it, they like to see how it's done, they like to feel how it's done, so I try and cover all of those different areas as well. Some people respond to different cues, so there's quite a nice one about the headlights, isn't there? Pointing the headlights of your ASIS, pointing those down and up, or the old gunslinger analogy as well, works quite well, pointing the guns forwards and back. That's my basic one that I would start to use to get them moving.
And I think with the pelvic tilting as well, it's also it's a fairly basic movement. So if you've got someone, with a lot of these differentiation tests, you're thinking about your sin factors. So you're thinking about your severity, your irritability, your nature. Specifically with the severity and irritability, if someone's very irritable at the moment, you might want to do tests that aren't necessarily going to really wind them up straight away, because that would then lead on to pain, which is then going to influence the whole rest of your assessment. So I think that's an important point as well, differentiation tests. Cool, so pelvic tilting. Then if we're looking at our lumbar spine and our hip in terms of flexion, what would we look for with that?
Well, you'd look at the movement first of all. So if I get you to flex forwards as if you're touching your toes, and if again, it's always worth thinking out what's moving here. So we're flexing the lumbar spine and we're flexing the hip at the same time. SIJ involvement also. Yeah. So if I get you to come back up for me now, PJ. If I get you to do what we call waiter's bow. Yeah. So I'm gonna.
So maybe PJ, if you come to the side, so they can see what your lumbar spine's doing.
Yeah. I want you to bend this time, but I want you to keep your back in a nice neutral position. I want all the movement to hinge through your hips, and then hold that, you're starting to flex a little bit there, so imagine you're bringing your chest forwards and up, hook under your chest bone, that's it, come a little bit higher again, there we go, hold that position for me there. So now what we're doing, and come back up for me PJ, we're flexing the hip, but we're not flexing the lumbar spine. Yeah, so you'd probably want to do a couple of repetitions until that technique was spot on, but what you're doing essentially there is you're taking out the lumbar flexion component of that movement. Yeah.
So again, if they had symptoms with the normal flexing forwards and then you changed it to a waiter's bow and they then did that movement and it wasn't painful, what you could say is that the lumbar spine was maybe more involved, because when you involved the lumbar spine it was painful, when you didn't involve the lumbar spine it was less painful, or the other way around. So then the other way around would be maybe more of a hip component. If you kept the lumbar spine nice and still, and you were moving and you were still getting the same symptoms, so the same pain, then you could say, well, we're still flexing the hip and we're not moving the lumbar spine, so then it might be more of a hip component that we've got going on.
The other thing that you can add in at this stage as well is a little bit of compression, a little bit of pelvic compression. Okay. So you've sort of taken the lumbar spine out when you do your waiter's bow, but there still might be some force closure issues around the pelvis, so we can add that in and just get PJ to either do his lumbar flexion movement or to do his waiter's bow movement, depending on what you see initially. So if the pain was absent with the waiter's bow, I wouldn't do that at this stage. I'll do it with the normal flexion. If the pain was still present, then I'd get him to do it again. And now I'm checking hip versus.
And where are you putting your hands? What are you pressing?
I come round, I find the iliac crest either side. I just come a little bit lower than that, and then I just provide a little bit of compression.
You're just compressing through. And again, then, with that force closure being the muscular closure or the muscular control through there, you're providing essentially support. So potentially if someone's really weak or has very poor kind of stabilisers around there, if you give that compression, it might sometimes reduce pain, which may suggest that some form of stability training in your program somewhere might be of use in order to reduce that pain. Definitely. Again, you're not saying definitely, you're just saying that you're giving a clue as to what you might use going forwards.
Yeah, exactly. If that is beneficial, you can take that a step further, teach them the kind of core activation exercises that you might like to give them on cues when they're moving, maybe glute squeezes, stuff like that, to investigate that a little bit more as well.
Okay. And then what if we're looking at more our extension, so differentiation of extension, lumbar, spine and hip?
Yeah, extension's a good one because again, if we get PJ to lean back here, we get an extension in both joints. Yeah, so we get an extension in the lumbar spine and we get an extension in the hip as well. So if we get you to come back here for me, PJ, what I like to do, I just usually use the couch. Normally it would be a unilateral problem that you see, not always, but usually it's left or right sided pain that they're experiencing, particularly if you're differentiating between these two areas, because it's normally going to be kind of buttock or lower limb area, which is why we want to differentiate in the first place. So if we're saying there's a left-sided issue, if I get you to face the wall for me, PJ, and just pop your left foot up on that step for me, there we go. And now from this position I'm going to get you to extend back, yeah? If balance is an issue, you'd provide a little bit of support for that as well, obviously. And now we're extending through the lumbar spine, but this left hip is being held in flexion. So if the pain was the same and there was no change there, I'd be directing my attention for the rest of the assessment more towards the lumbar spine. If the pain was significantly decreased, I might want to look a little bit more at the hip. Yeah.
Okay. And then if someone came in and had more of a rotationary problem, so this might be when someone comes in and said that more twisting and turning issues were giving them their pain, then how would we differentiate between the lumbar spine and the hip?
Yeah, it's a little bit harder, that one. The rotation's a bit trickier. You see it a lot with golfers and all that kind of stuff, but it's really nice to have something that you can do at this stage to differentiate and give you a few cues again. So for this one I use a Maitland test actually. If I get you to face me, PJ, and pop your hands onto my shoulder for me, that's it, and then rotate and step your foot around. There we go, good. As he comes there. So what we've got here now, PJ's rotated his lumbar spine and he's internally rotated his hip as well. I'm going to bring my hands on here and I'm going to just add a little bit more rotation that way, and I'm going to fix that out. Yeah. And then what I want to do is get PJ to put his hands on my opposite shoulder and then look over his right hand side. There we go. So now we've kept that component on at the hip, but we've released that rotation component at the lumbar spine. Yeah.
And so if PJ was getting less pain when he put his hands onto your other shoulder, that would show that potentially it was a lumbar spine issue, because you're releasing that lumbar spine component of the rotation
whilst you're maintaining the hip.
So, and if the pain stayed and didn't improve, or didn't, then you might think it was more hip.
Exactly. Yeah. Exactly right.
Cool.
That one's a little bit more provocative, so I would be a lot more wary of my sin factors on doing that one. Yeah. So if somebody had 8, 9 out of 10 pain that takes a few hours to settle when you provoke it, probably not the best test to do at that stage, but good to have in your armoury for the lower irritability patients that you see. Okay.
And then the other thing we've got with our SIJ is our Laslett test. So Laslett is a guy that did some study on the SIJ and found that there was 5 main pain provocation tests that you could use, and was quite reliable at seeing whether there was some SIJ, or if the SIJ was a source of pain. And what he said was that 3 of these 5 tests needed to be positive. If under 3 of the 5 tests were positive, then it was very unlikely that it was an SIJ problem. Okay, so now we're going to do the Laslett test for the SIJ differentiation. So we're going to get PJ to lie in supine, so lying on his back. We'll come around the other side. So first of our 5 Laslett tests, essentially Laslett did some research and found that for the SIJ there's 5 tests if over 3 are positive for pain provocation, so if it's painful in over 3 out of 5, then there's a high chance of there being some SIJ involvement in terms of the source of pain. So the first test we're going to go through is Gainsland's. Again, we're going to go through these quite quickly. It's more of a differential diagnosis rather than a special test, so we're just going to be looking for pain. Okay, so as we do this one, we're looking for pain. So on the right, for the right SIJ, I'm going to bring the right knee into flexion. We can bring the foot against the chest to add some extra compression. I bring my opposite hand onto the other side, and then I'm just going to lean in and I put some compression through both the hand and through the chest, and I'm just asking the patient, is it painful as you do that? Once you get an answer for that, just make sure where is the pain, okay, and don't lead them. Okay, make sure that you ask open-ended questions. Don't close questions and say, is it painful in this place or that place? Just say, is it painful? And if they say yes, where is it painful? Okay, and then they'll either say round the back into the SIJ region, which would suggest more of an SIJ issue, or they may say around the front, which again, you're going into a lot of hip flexion, so there may be some hip issues there. But again, what we're really looking for is pain in this SIJ region, and then we're looking to have 3 of the 5 tests positive. So that's Gainsland's, the first one. Then we're going to do a hip thrust. So there's a couple of ways of doing this one. Just chatting to Glenn earlier, and we were talking about the fact that it's quite nice if you bring the leg across, so you're rotating the leg across, just bringing the hand underneath, so you're onto the SIJ, so you're feeling for that SIJ, and then bringing the patient back onto your hand, and then getting over the top and getting that thrust through the femur, so you're thrusting straight down. Sometimes, and again, you can come into a little bit of adduction, so about 10-20 degrees of adduction, and the same thing, and you're just looking for pain. Okay, so is there pain, and if so, where's the pain? Again, sometimes what you might find to get that adduction and to really compress through, if you've got someone who's quite big, then you might have to do that with double hand position. But again, it's nice to have the hand underneath so you can feel what the SIJ is doing. And then we've got our distraction tests. So for this, we're going to cross our hands across onto the ASIS, again getting into a good position with the back, and we're just going to press down and laterally through the ASIS with our thenar eminence on the hand. And again, is there pain? Is there no pain? Okay. Third one is a compression. You can do this in side lying, but again, for our differentiation, because we want it to be a nice quick test, we're going to come in onto that onto the pelvis on both sides, and we're going to compress through. Again, I'm trying to keep my back fairly, so I'm basically keeping the lumbar spine extended as I lean over. I'm not caving in through, because again, for me, that's going to be bad for my back, so I'm making sure that that lower back is in a good position. Again, asking for pain, where is the pain? So that's our compression. Then we've got our sacral thrust. So if we come onto the front,
I think in this position it's quite good to just go through some hip stuff also, though, isn't it?
Oh yeah, yeah, absolutely. So if we we go through our hip as well, we can go through our quadrant. So if you go through a quadrant for the hip, so again, you're coming from an extended position, you can come right up into flexion with a bit of adduction and internal rotation. Okay, and again, you're looking for pain as you do that. And what you can also do is a bit of circumduction, so you're basically coming from a flexed, adducted, internally rotated position into a flexed, abducted, externally rotated position. Okay, so as you come round, you're essentially getting the different motions of that hip joint. So if the hip does have some pathology there, you might well find as you scour through the hip, sorry PJ, that you get a little bit of pain provocation as you do that as well. Would you do anything differently with that one, Glenn?
Yeah, I think if you get the pain, which is in some respects what you're looking for, this movement, isn't it? Then a little bit of traction to the hip joint is quite nice.
So distraction through.
Yeah.
So again, yeah. So to see whether the distraction component has an effect, it's a very good point. We maybe would put some distraction as we came up into that flexion position. And again, you can do this sometimes with a seat belt as well. So if you have a seat belt wrapped around the thigh, wrapped around your bottom, just pushing back with that so that you get this distraction through, and then just passively flex up into that position. What that will do is it means the femur is distracted a little bit out of that acetabulum, and therefore again the contact forces aren't going to be the same, and if it reduces pain down, you might feel that there's an intra-articular problem maybe there, or a hip pathology problem that is better. And again, all you can say at that point is that the pain is better with distraction. You can't say that you can't diagnose with that, but you can certainly say that again the hip is likely to be involved if you've got pain there, and then when you distract it reduces that. The likelihood is that it is going to be a hip issue or some a hip pathology of some sort. So we've done the hip in this position as well. If we come onto our front, we can also do our sacral thrust, so we'll do that now. Okay, so again, we've got our hand onto the sacrum and we're just pushing 45 degrees and just pressure through in order to see if there's any pain provocation. Okay, so we've got our Gainsland, our hip thrust, our compression and distraction, and one other actually for the Laslett tests. If you come onto your back again, PJ, sorry, move you around a lot. And is our Faber's test. So out those 5 tests, so we've got our Gainslands, hip thrust that we did, compression, distraction, and then our Faber's. So Faber's is just bringing the foot onto the opposite knee. Okay, so again for the right SIJ, and then you're going to bring your hand onto the ASIS and just push through that knee to look for if there's any pain provocation on that right hand side. Again, with this one, you are going to get some hip, you are moving the hip, you're going into a bit of flexion, abduction, external rotation, which is why it's Faber, flexion, abduction, external rotation. And you're also stretching those adductors. So again, you have to ask where that pain is when you do that. So if there's not 3 out of 5 of those 5 tests I just mentioned which are painful, then you can pretty much rule out the SIJ. But again, as Glenn was talking about, it's good to do those hip differentiation tests while you're in this position. So next we're going to go through our neurological differentiation tests. So the first one we're going to do is just our simple straight leg raise in supine line. So I'm going to get PJ to lie onto the couch. I'm going to come round this side, I'm going to do the straight leg raise in this position. So what we're going to do is we're going to have the hand blocking the knee, and then keeping that foot in dorsiflexion, we're going to come up. And again, you just be asking for symptom provocation, again, where they feel the pain, what does it feel like, you're just looking for those qualities. Then you can come in to block the knee, and then you can come on to doing your plantar flexion, dorsiflexion, again asking for that symptom provocation, what happens to the symptoms, do they change, how do they change. And then what you can also do is the head section of the test. So PJ, if you flex your head towards your chest for me, so chin to chest and then back down, and then again asking, does that change, does it bring on more symptoms, again where are the symptoms when it does that. The other thing that you can do with your straight leg raise is slightly bias different areas, so you can adduct the leg as you're coming up. You can change the position of the ankle as well into more dorsiflexion, eversion, or you can come into plantar flexion, inversion, which is going to get different parts of the nerve, or bias different parts of the nerve. But we're going to go through that in our neurological video. So if you have a look at the neurological video, we'll go through those tests in more detail. This is just going to be screening for to differentiate whether there is a neural element. So we're really just looking for the basic tests with this. And if you do find then that there is some neural components, then you could go into it in further detail when you do your neurological examination. So next thing we're going to do, Glenn, is going to be the slump test. So if you go through that.
Brilliant, yeah, so if I can get you sitting, first of all we're going to get PJ sitting on the edge of the couch. Bring the bed down so he's in a nice position. Probably one of the only times we're going to get our clients to sit in a poor posture, so I'm going to get you to slouch forwards for me, PJ, that's it, and hands behind your back. I'm going to come and sit alongside him. Now I'm not going to force his head down, but I'm just going to rest my hand there as a little bit of feedback for PJ so he knows to keep that position. And then what I'm going to ask you to do, if we were looking at the right leg, I'm going to hold that position. I want you to just very slowly straighten out that leg for me. That's it, pull your toes up as well. And then from here we can differentiate it by just bringing the head up and then bringing it back down. Now PJ's got good mobility there, he's got good neural mobility. If he was restricted, we might get to say 40 degrees, that might be enough for him, that's as far as he can go. We would hold the head position and then just see what happens if we bring on some dorsiflexion and release that off. We can differentiate from top and bottom. Nice little way of looking at what's influencing it more so there.
I think it's important when you're doing this one, and seeing it from here, I can see with Glenn's handling, is that he's not letting, when he's letting PJ extend his head, he's not letting his thoracic slump go. So I think it's important to really make sure that you don't allow the person to move their upper body back when they do that with their head, so it's just the head, otherwise you're going to kind of, you can get a false positive test. So you need to make sure that the position they're in stays in that slump position.
Yeah, every part that you wind up you want to maintain with the differentiation aspect that you put in, essentially. A simpler version of that as well, if we bring PJ into standing, going back to our sort of general range of movement testing, if I get you to bend forwards for me, if you wanted to just do a quick look at neural contribution to the symptoms, if you just pull your toe up and dorsiflex from there, that would be quite a nice way at the start of the assessment to see if there's any neural contribution to his pain.
Perfect.
And come back up. But like I say, we can go through all of the neural testing in detail in the neurological examination video.
So that would be our simple little differentiation tests to see if there was a neural component if you've got your SIJ, hip or lumbar spine pain.